So, touchdown, Hyderabad. It's a great pleasure to have Dr. Hari Kishan with us. Hari, great pleasure. How are you? Hopefully ready to go. So the stage is yours. EBUS guided mediastinal cryobiopsy.
Professor Felix, many thanks for the opportunity and welcome. Greetings from Hyderabad. Very good morning, and we have a very special guest, Professor Felix. I hope you can identify who's standing on the right of me, Professor Venerino Poletti.
No.
So he was here for a national conference, and then he wanted to come for this program and speak to you. So once again, greetings and thanks to the Pulmonology on Air, second edition global chapter. Last year, we performed mediastinal lymph node cryobiopsy using the needle and then the conventional EBUS TBNA needle, followed by a cryobiopsy using 1.1 mm cryoprobe. This year, we try to do it the Professor Felix way. So we try to show the procedure using the electrosurgical cautery cut and then pass the cryoprobe and then take samples from the mediastinum. So coming to the patient details. So this is a patient, female patient. "57-year-old female, no comorbid illness, but presenting with cough and expectoration for the past 6 months. Shortness of breath and few streaks of blood in her sputum. And then her CT was done outside, and then she underwent a bronchoscopy for evaluation of a right hilar lesion, but it was not consistent with any abnormal pathology in the endobronchus. So before beginning the procedure, we would like to do a first conventional white light bronchoscopy and then see if there is any endobronchial pathology. Following that, we will shift to the Fujifilm 530 US and then try to do a mediastinal cryobiopsy using the needle knife technique. So we use a 530T adult bronchoscopy to use and for we use an igel as a conduit. So our practice is like we do EBUS under general anesthesia in all the patients. We don't use rigid bronchoscopy. We use an igel. And then here you can see the endobronchial mucosa. Some maybe there is a habit of chewing tobacco in Indian subcontinent, so you can see some traces of black material in here. And then the carina looks little distorted to the left side, little deviation, but no endobronchial evidence of any malignancy. So we quickly inspect the left tracheobronchial tree. You can see some secretions out there. And then moving on to the right side, you see some extrinsic compression here, especially in this hilar area. So no endobronchial pathology as such, but there is some edematous mucosa and also some extrinsic compression in this area. So we quickly shifted to the EBUS. So a PET CT was done for this patient, and she had a positive PET avid nodes in station 7 and station 4R with a right hilar lesion.
So I think what we can see nicely through the forward viewing of the EBUS scope you are using, it's nicely to use, and due to the video signal, you really have a good overview, and you can really use the same scope to scan through and then do the EBUS procedure. So it's really nicely to see straight ahead.
Yeah, Professor, I totally agree with you. And this is very advantageous, especially in this mediastinal lymph node cryobiopsies, because you have a very clear view of the endobronchial tree. And the main difficulty doing this procedure is like passing and identifying the same orifice where you create the tract. I think this scopes makes it more easier. Like here, you can see a station 4R lymph node on the right side. And then we quickly shift to the subcarinal area. And then you can see a big subcarinal lymph node around 2 centimeters. So here what we do is we try to use an electrosurgical needle knife. So what I was discussing is like nowadays we started doing straight mediastinal cryobiopsies. Like we don't use the needle anymore in any patient. So we try to avoid the cost of the needle by using cryoprobe with the knife straight up. So once we identify and localize the lesion, Professor Poletti, you have something to add on?
No, I think. Good morning, Felix. I cannot hear you.
Good morning, Felix. Can you hear me? No.
So you use the Doppler function always?
Yes, because you can see here, like while we choose to puncture the area, like the entry area, there is one small vessel here in the entry point. So I try to avoid that area and then try to go a bit lower. And then first you can see on the top of the ultrasound where the electrosurgical needle is coming out. So I asked the assistant, Dr. Preeti, she will now push the needle out. So you can see the needle coming out. And then you can see the entry point on the right corner, right top corner, like the needle. So the usual practice for beginners is like some try to go on the mucosa and then start activating the knife on the mucosa. But what we do is like we just try to press the mucosa with the needle and then try to get the needle inside the mucosa, and then using the endocut eye mode, we make a small cut. You can see there, once you make the cut, just make your probe up and down, and then she will pull the needle inside. You can clearly see the orifice there. The main challenge here is like once the cut is made, try not to move the scope in any direction. Just maintain the position, and then the second operator is ready with the cryoprobe. And then I quickly sound. I'm trying to push my cryoprobe into, so sometimes you may have to pull the ebuscope a bit up. Now you can see it's going on to the capsule, and then, but now you can see I'm able to pass the cryoprobe inside. I hope you can appreciate the probe inside the lymph node, Professor.
Yeah, we're seeing the probe very nicely, and especially due to that metallic tip, you see that bright tip in the EBUS image. So it's really easy to see when you have the cryoprobe in the lesion.
And now once we enter the lymph node, what we do is like we try avoid not going too deep because you have vessels there. And then we try to move the probe up and down, and then see again the Doppler. If we have any vasculature, we try not to puncture in that area. And then I hold the cryoprobe, and then our activation time in our hospital usually is only for 3 to 4 seconds for malignant diseases. So once I am freezing now, 3 seconds, and then I pull out. You can see the tip of the cryoprobe with the tissue material.
Yeah, maybe you have to zoom in. Yeah, then we can and switch out the
Yeah.
light of the scope. Then we can see it.
Light. Okay. So what we also practice, like we do an imprint cytology of all the samples what we receive on this, and then we have rows.
So Harry, there are a couple of questions. I think we have good literature even also from your center, that we have an increased diagnostic yield in non-lung cancer patients when we're talking about lymphomas, sarcoids, or whatever. Do you use the cryo in the mediastinum also in lung cancer patients to have better material for molecular staging, or you use the technique only in the non-lung cancer patients?
Professor, our practice is like initial days we started to do the procedure using the needle and then cryoprobe. Since the cost of the procedure was going high when we combine two procedures, now we do a straight procedure for all mediastinal lymph nodes that are accessible. We don't do conventional TBNA for even malignant pathologies.
Okay.
So we started to compare the cost and also mainly the time. So now you can see a diagnostic EBUS with this kind of a needle knife and then puncture and then getting two samples hardly takes 4 minutes to 5 minutes. And then we are able to save the cost for the patient in terms of operating room, anesthesia time, and the needle cost also. I think we are doing a paper on this looking at no needle technique, what we are calling this as, and then we get maybe hard. I think we are working together on this, and then we try to publish the literature. So do you have any comments on this? I know your RCT shows that in benign pathologies, it definitely makes a difference. But I think in timing of the procedure, like if you have a very busy center and then you have many cases, having a needle, trying to do 3-4 passes and then the rows, you can save a lot of time. And the imprint cytology, what we get with this cryoprobe is fantastic. Now the cytopathologist is here. While she looks at the samples, we try to go and see if we have any bleed or anything after the initial cryoprobe puncture.
So there's a question for you, Hari. In which cases you would not do a cryobiopsy?
So we very selectively we do cases in our center. We don't do for mediastinal cystic lesions for very high necrotic because we are an endemic country for TB. If we have a bad TB necrosis, we try and avoid mediastinal cryobiopsies. And also if you have very large vessels, then in these three conditions we try and avoid doing cryobiopsy in these patients. And then we go for the second pass while the cytopath looks at the stains. So sometimes the initial puncture sometimes may be a little tough because the probe sometimes can go on the capsule and then cross it. But when you go for a second pass, usually the puncture site, if you are able to identify quickly, it will be very easy to push the cryoprobe. Now you can see the entry of the cryoprobe.
So how many specimens you normally take?
We take 2 or 3 specimens, Professor, in our practice. So this is a different area what we actually are taking samples from. We are a bit subcapsular in this plane. And then again, you can appreciate the probe. So what is your feeling on this, like not using needle at all and then go with the cryoprobe as the first tool?
Yeah, you see that the point is really the issue that we using it, as mentioned, we're using it more in the non-malignant cases as it has been published. But I know that Venerino and Jürgen Hetzel, they're looking for the value of the results of the NGS analysis of cryomaterial compared to classical material. And what Jürgen told me last week when I met him, that he has the impression that by cryo you get also more often an NGS positive signal So I think what we really learned from the beginning, bigger is better. I believe that taking out more material is better to come up with a more precise and phenotype diagnosis. So therefore, I think cryo-mediastinum biopsy will become one of the standards because we really getting out better material or more material. And I ask you, have you any severe complication by all your cryobiopsies of the mediastinum?
At the moment, no, Professor. We did not have any complications, but some cases where we were not able to pass the cryoprobe due to very hard lymph nodes and the capsule being very tough to cut.
Yeah.
And our center, we also do very selected stations like station 7, 4R, 11L, and 4L. We are not, and size doesn't matter. Actually, we are publishing a series where the smallest lymph node is of around 7 mm in 11L station.
Okay.
So this is our experience, and I will go for the third pass. So sometimes
I
when
think I agree. We are not always able to put the cryoprobe in, because sometimes the lymph nodes are the capsula is too stiff, or maybe cartilage issues. So therefore, I often got question: can we do a cryobiopsy of the mediastinum without EBUS? I would not do that without EBUS because you have to know where the tip of your probe is. There are larger vessels around, and you don't want to take a cryobiopsy of the vessel wall.
Yep. So now we see the cryoprobe again in different location. There is a question like regarding fanning with the needle and with the cryoprobe. Once you make a clear orifice, I think. But I think again, talking on fanning and trying to do with the needle, because of the cryoprobe having a 360-degree biopsy capability, that may not be a very important thing to do. Like you don't have to do in different areas. Most of the times for simple malignancies, you get diagnosis on this. And then I go for the third pass now. So we'll try to increase the freezing time. And then now I think you can off the light.
It's
Clearly
bigger, yeah.
appreciate the bigger sample. So the more as you keep doing the passes, because the initial orifice where you create the path becomes a little loose, you get more tissue when you freeze for longer time. So for the first pass, we try not to do for more than 3 seconds, because sometimes we have difficulty getting the material outside.
Felix, can you hear me?
Yeah, sure.
Good morning, Felix.
Hi, Benarino. You have you booked the learning course by Hari.
It's a pleasure to be here. It's a great pleasure. It was a very nice case, yeah.
Yeah.
And I agree with you that probably for NGS, in which we analyze more genes, more material is needed, yeah.
And then we go and inspect. You can see there is no bleed or any other complication. I think 3 samples are quite good enough in this patient, and we wait for the cytopathologist to get us the slide review done. And meanwhile, we can take some questions, or if you have any comments on the procedure, we are happy to discuss.
There are multiple questions for you on the on the chat. So the first question: which type of electro-knife you used?
We use the knife from like we have local made knives in India, mainly from the gastroenterology department. So we have many companies that make electrosurgical knives in India. So it really doesn't matter what type of knife you use. You just need a small tip, and then the system via 3 system, then that will help us.
Yeah. So that what Hari mentioned, you just have to make a small incision and open the capsula, and then it's not longer an issue to bring the probe in. And also there have been initial trials published where they look 2 days after again in the patient to see what happens to that little incision. And 2 days or 3 days later, it's even hard to see or to find the incision again. So the body really has amazing healing possibilities. So it's really a safe procedure. As Harry mentioned, complications, 0.
I totally agree. Complications are 0.
Yeah. So we are not as lucky as in India. In Europe, we do not have so many companies providing us the electro knives, but there are 2 or 3 companies out, and you just make a small incision and then you are in. Yeah. Any post-procedural precautions you do, or handle you the patient? Do you handle the patient after the bronchoscopy like every other patient you do procedures?
Yesterday's.
Harry,
Yeah. So sorry, Professor, I was with the cytopathologist. Can you just repeat?
if you deal with the patient in the same way you deal with other procedures,
Yeah.
or you have a specific
After the procedure.
After the procedure, our practice is like we don't administer any antibiotics for patients after EBUS TBNA. We, as a part of study, we call them and then on a telephone and ask if they experience any major complications. So when they come with the slide review, we tend not to do bronchoscopy because initial days we started doing and seeing if there is any problem with the mucosa. But once we understood that nothing happens in the area where you make a puncture, so we stopped doing a surveillance bronchoscopy on these patients to see what exactly happens there.
Okay. And again, there are a lot of questions regarding the incision. So do you have specific settings on the machine for the incision, or you just use the standard setting?
So we just use the standard setting endocut eye, and then we make a small incision. For those, there are a lot of questions on the electrosurgical knife, what to use. If you don't have a specific pulmonary knife, you can just borrow from the gastro colleagues and then use the knife. This is a problem in many centers because many countries doesn't have a specific pulmonary endocut knife.
Yeah. I think this is important information, that the knife is not really something where you need something special. You just need one, yeah. And use it and use the normal session, because it's only really a super short incision you do. So we have seen Harry doing that. This was less than 2 seconds, and then the incision was made. So everybody's waiting for the cytology or for the material.
Yep.
Exciting time, yeah.
Yeah, you showed them yesterday. Maybe you can comment on the slide.
Yeah.
Okay, great.
It's anthracosis.
There are some atypical cells in the slide. So the pathologist says he sees some atypical cells, and then we wait for the histopathology reports after 2 or 3 days.
Yeah. So the great. You get the diagnosis. We wait for you will get the final results. But it's really helpful to have the possibility to have rapid on-site evaluation, because you get a feedback. Do I need another specimen, or is the specimen you sent me already useful to come up with a diagnostic procedure? So regarding the procedure, do you have had the patient on the laryngeal mask? You believe that is also possible in local anesthesia? You need a laryngeal mask. You need a rigid scope. So in which setting you believe we can use the cryo probe for the mediastinum?
We have experience on doing this procedure under conscious sedation as well in patients who are not fit for general anesthesia. But ideal practice is to do under IGEL, because the patient doesn't move, and you don't want the probe to get, because this is a procedure where you need to have a clear entry point, and then if the patient starts coughing on, it really troubles you. So our practice is like all the patients who are fit for anesthesia, we do the procedure under general anesthesia with the IGEL. But in those patients who cannot tolerate, we have done like in our series of around 120 patients now, we have 3 to 4 cases where we used conscious sedation.
Yeah, I think also what you mentioned before, that in your trial you went down to 7 millimeter with the cryoprop. I think when you really go for tiny lesion, the patient should be somehow paralyzed, that he's not really coughing exactly then when you would put the probe in, because 7 millimeter is 7 millimeter. I think when you have really a large lymphoma, you maybe should be able to do that also without general anesthesia, but especially when you go for the smaller lesions, I think it
And
matters
one
that
more,
the patient sleeps. Yeah.
yeah, one more point I would like to add. Like we have all the three EBUS systems in our unit from all the different manufacturers. But
Okay.
mediastinal cryobiopsy with this Fujifilm EBUS, it makes it little more easier to puncture, because you have the needle and the cryoprobe coming straight in front of you. So you have a clear vision where you're going, and then you don't, because the other scopes, the needle comes from a different angle. Here it's a straight path, and then it's very easy for you to pass the
Yeah.
cryoprobe.
Yeah. Yeah, you are a rich man, so you can get everything you want. Yeah? Normally, the units have access to one ebuscope. So we have to send everybody to Hyderabad. So great case, Hari. Thanks a lot. Just for your information, we will have an Asian chapter on pulmonary hernia, and Dr. Hari Kishan is the leader for the Asian chapter. So when you registered on pulmonary, you will see him again with an Asian event. But if you are from South America, you just will see him again in the next global event next December. So Hari, thanks a lot for showing that case, sharing your experience. Thanks a lot to your team, and special thanks to Venarino. Venarino, you learned a lot today.
Yeah, it's true.
So go home and start cryobiopsy of the mediastinum. So thanks a lot. Great case. Thanks to the whole team, to everybody. And see you again somewhere in the world next year. Have success. Bye-bye.
Thank you, Professor. And we're looking forward for the next Asian chapter.
Good.
Bye
Bye-bye.
bye.